Hello everybody, irrespective where you are around the world. Welcome to this WFNR short webinar celebrating Brain Awareness Week, coming the end of Brain Awareness Week, but we would take the chance to shed a little bit of light how we feel about brain restoration and the goals of Brain Awareness Week. During this webinar, I have three very distinguished partners with me this afternoon. It's Professor Mayuba Volabi from Nigeria. It's Professor Nomal Soya from India, Mumbai, India, and Catalina Pistarini, the Secretary General of the World Federation as well. I will start with a short introductory video on our ideas and future for rehabilitation and how we conceive Brain Awareness Week. Christian, be so kind and start the video, please.
So, hello everybody and welcome to this short webinar celebrating Brain Awareness Week this year in 2024. WFNR and our partner organizations are proud to support Brain Awareness Week again this year. I think we have a goal to alert the world on the enormous impact of brain health on the future of mankind. Over the last year, there is some sort of an increasing depression, not at least due to the fact of growing outbreaks of violence and wars around the world. On the other side, we have to see that we are in a position as we've never had before. We are standing in the front of a new open door for a revolutionary change in medicine, which will have dramatic consequences. This is due to the fact that we have better scientific understanding and we have better resulting therapeutic options, which may open chances for curing diseases and enable us to come to more focalized approaches. And finally, using digital technologies, it may be very helpful to roll out skills and knowledge worldwide in an easily accessible and affordable way. And WFNR believes that neurorehabilitation will be in a pivotal position to decrease disability worldwide. Some words about the World Federation of Neurorehabilitation. Our mission is to advance research, education, and clinical practice in neurorehabilitation throughout the world. We have more than 5,000 members around the world. Most of them are organized along 42 national societies. So far, the number of national societies is increasing year by year. We have a lot of activities going on. You will get the information in detail from the website, as you can see. And well, you're cordially invited to become a member of the WFNR, and as you can see from this slide, there are a lot of advantages. You can be part of a huge international network with a lot of educational and information spreading activities, and you have free access to our journal Neurorehabilitation and Neurorepair, which has an increasing impact factor year by year. Let's look at the global situation. All of you are familiar with that. These are just the key facts published autumn last year by the World Health Organization, stating that over 1 billion people live with some form of disability, and the number of people with disability is more or less increasing, not at least due to the COVID-19 pandemic. That, of course, sets goals for rehabilitation. And the general statement of the WHO is that 1 in 3 people today are estimated to be living in a health condition that benefits from rehabilitation. So rehabilitation is an essential part of universal health coverage. And globally, an estimated 2.4 billion people around the world are currently living with a health condition that might eventually benefit from rehabilitation. So that is a real significant task to look at. When you look at the global situation in terms of availability of trained staff, there is, of course, a tremendous difference between low, middle, and high-income countries. When you look at Africa, for instance, we have about 3,000 and more people for one physician, whereas in Europe and the United States, it's about, and in North America, it's about only 10s of that. So For neurorehabilitation, the question, of course, arises, what options do we have, high-tech and low-tech options? We have certainly learned to conceive neurorehabilitation today as a form of an applied neuroscience. And this is an old slide, looking at what strategies we have available to do neurological rehabilitation, then we end up with some sort of a hierarchical structure. Of course, it would be desirable as a restorative approach to replace the dead issue. Most of what we are doing, however, is to teach bypass strategies or replace functions by aiding devices and similar strategies. So let's look at some high-tech options. These is just a individual selection. There are certainly more available. We have dealt with intelligent mechanical training devices, also known as rabbits, with VR, AR gaming technology for motor and cognitive training, with brain-computer interfaces to be used for prosthetics or for retraining cerebral networks, and of course also neuromodulation strategies by peripheral or central stimulation by TCDS or transcranial magnetic stimulation means. But we should not be too enthusiastic about the high-tech options. We definitely have a lot of very appealing low-tech options. We have learned an awful lot over the last decades from elementary rules of motor learning, and learning-based coaching strategies and procedures are very important for especially motor rehabilitation and partly also for cognitive rehabilitation. That spreads, of course, into community-based and caregiver support options and self-training strategies. All of this is low-tech, can be done without any sort of technology, just with a patient or caregiver to patient interaction. This is just the example of elementary rules of motor learning, and we learned a lot about that. Repetition is important, the application of feedback and knowledge of results, shaping the task as to what the patient is just able to do, going for active performance rather than synthetic environments. If a patient wants to walk, you have to train walking. If a patient wants to grasp, you have to train grasping. Ecological validity is important. Motivation is a completely neglected field, yes, in the field of neurorehabilitation, which we certainly have to attribute much more attention to. And some other aspect, competition modulation, all of this is certainly important in motor learning. The winner of all of the so far used therapeutic techniques certainly is constraint-induced or forced use therapy, which has been shown in many studies to be available in a very low-tech way, if you like, to avoid learn-on use, and it's applicable in acute and chronic conditions. So we have certainly learned quite a lot about principles of motor learning, but the question remains, are these motor learning or learning principles in general really direct drivers of plasticity? And this is still an unsolved question. So the bad news in this sense is that, as I mentioned in the beginning, millions of people in the world do not have access to decent rehab services. And high-tech options are useful, but most often expensive and not accessible to many, but only to the happy few remaining. The good news, however, is that reasonable rehab is not critically dependent on technology. I think that is a very important statement. Knowledge about learning and coaching strategies is of high impact. Community and caregiver-based approaches can be widely used. And I come to an important point. Digital communication tools offer chances for low-threshold, easily accessible spread of knowledge and techniques. If we have learned anything from this bad COVID-19 pandemic, then it was that our ease in using digital communication tools has very much improved almost everywhere. I'll give you an example. So we expect that digital communication tools for low threshold spread of rehab knowledge and procedures will become an important issue for us in the future. I'll give you a very short example for possible application of a digital communication tool for the problem of long COVID. We try to embed that into a easily accessible app, having aspects of cognitive training, relaxation, have a chat room available for long COVID problems, a behavioral manual where people can look at that. We have VR tools available and pain control issues and many other features of that, which is easily programmable and codable. And we happen to make this available as an aiding app now in 11 languages so far, which are available, and this software is available free of charge around the world in these 11 languages at the moment. Well, following these lines, WFNR has decided to come up with a complete representation, digital representation of a rehabilitation setting in the metaverse, if you like this wording, which will allow, by use of artificial intelligence, a dialogue between the user, maybe a patient, maybe a relative, a caregiver, or a professional. If there are any questions concerning strategies and procedures for rehabilitation, I will give you a short glimpse on this. Note that this is work in progress, and we are heavily working on this. So over the years, we have seen a tremendous increase in the number of high-quality trials in the field of neurorehabilitation, which is good. But does this mean anything when it comes to possible game changers in the field? So let's look, if we had real game changers. We have made tremendous progress in spasticity treatment by botulinum toxin, baclofen pumps. I mentioned constraint-induced movement therapy already as a easy administrable tool, and we will certainly see more on the usefulness of multimodal drugs in improving brain plasticity. The question, however, is if we have an epistemological problems, we were adherent to evidence-based medicine, and we still think it's probably the best way to base clinical decisions on knowledge. But in some sense, it may even hinder the further development of the field. And science cannot always be put into randomized controlled trial framework. And therefore, this rationale is not apt to generate ideas against the mainstream. Especially, it is not very much in front of focalized or really individualized types of clinical decisions. This is a short list of future perspectives to the end of this decade. We will certainly have further progress in neuroscientific understanding. We will probably see a lot of improvement in personalized rehab approaches based on biomarkers as imaging, genetics, and so forth. We will see an implementation of easily accessible digital communication tools for spreading of neurorehab knowledge and procedure. We hopefully get deeper insight into motivational resilience problems within the rehabilitation process. We might come up to the fact that we have better focalized trials for precision medicine, especially asking the right questions. a more focalized development of plasticity promoting pharmacology, I mentioned already, and a more clever epistemology, also beyond the framework of randomized controlled trials and meta analyses. And of course, we need more attention to emotional and spiritual elements in the rehabilitation process. This is all I want to say for today. I just want to alert your attention to the forthcoming 13th World Congress for Neurorehabilitation in Vancouver, Canada. Canada, in the end of May this year. Would be more than pleased to see you there. Thank you very much for your kind attention.
Okay. I think we should have a general discussion at the end of all the talks today. Our next speaker probably is Mayova, right? Mayova Ovolabi, neurologist from Nigeria, one of the leading neurologists in Africa, an extreme good partner for us in all we're doing in World Federation of Neurology work, especially also concerning special elements of low middle income countries. So Mayova, go ahead.
Thank you very much. Hope you can hear me.
Yeah.
So I'm going to be talking about promoting neurorehabilitation in Africa through community-based rehabilitation. So we have probably seen this before. We know that neurological conditions are the fastest growing cause of death among the NCDs. And in terms of costs, economic burden, stroke costs about 900 billion US dollars per annum, and this is projected to increase to over $2 trillion per annum by the year 2050. As of 2019, dementia alone cost US $1.3 trillion. In the past 3 decades, there has been 40% increase in number of deaths from neurological disorders, and neurological disorders affect 1 out of every 3 people. And in fact, neurological disorders are the leading cause of disability-adjusted life years across the globe. Hence, the required attention to neurorehabilitation. And when you look at conditions that are responsible for these disability-adjusted life years across the 21 GBD regions, you will see that stroke tops the list across all the regions, followed by neonatal encephalopathy, migraine, Alzheimer's, meningitis, idiopathic epilepsy, neural tube defects, head injuries, traumatic brain injury, traumatic spinal cord injuries, encephalitis, movement disorders, and so on and so forth. And when you look at this across the life course, you will see that stroke is predominant from middle age, and then dementia takes over from middle age to older age groups. And when you look at the burden in terms of DALY's rates of neurological disorders for all ages in both sexes, 204 countries and territories, you will see that the burden is very high in LMICs. And that seems to even be getting worse. When you look at the burden from 1990 and try to compare to 2019, stroke remains on top, followed by neonatal encephalopathy. But then headache disorders are gaining more prominence. Infectious disorders seems to be receding. So a neurology revolution is certainly required to draw attention of and put neurological conditions at the center of the global health agenda and global development agenda. So the game changer actually was the WHO Intersectoral Global Action Plan against neurological conditions that was launched in May 2022. And within the context of this, the care continuum, of course, rehabilitation is a key pillar, which should be integrated into promotion, prevention, diagnosis, treatment, which are also equally important, particularly in LMICs, where rehabilitation services is very scarce and hard to come by. And it must be integrated in the continuum of care for mental health conditions, communicable diseases, NCDs, and so on and so forth. So global synergy is required to improve brain health for human development. Without brain health, there is no health. And without health, there is actually no wealth and no development can happen. Brain health is so, so important and central to human capital, to brain capital, uh, cognitive skills that are required for productivity in the knowledge economy, which we are all experiencing. So brain health is fundamental as well for physical and mental health, social health, economic health, as well as planetary health. And fundamentally, spiritual well-being influences brain health. So there are four pillars of the neurology quadrangle. Surveillance, which is very important to know how many people really are in need of neurorehabilitation services across the globe. Prevention and promotion to mitigate and reduce the burden of neurological disabilities across the globe. Treatment and acute care, very important to reduce neuronal injury and neuronal damage and loss and increase the chances of recovery. And of course, even in acute care, rehabilitation is also integrated. So rehabilitation is very, very critical to ensure restoration and recovery and reintegration into society. So to realize the objectives of rehabilitation, of course, we know it's basically about realization of potential, re-enablement, resettlement, role fulfillment, readjustment, and is multidisciplinary, and that's one of the major challenges because not many of these disciplines are available at all places where neurorehabilitation, at all the settings, in all the settings where neurorehabilitation services are required, where there are patients who need these services to improve. But just to reinforce the fact that the patient is very critical, caregivers are very, very important aspect of the core ecosystem for recovery. And we need to work with caregivers and community members in the context of community-based rehabilitation. Of course, with physicians and therapists and different categories of therapies, which are language therapy, physiotherapy, psychotherapy, cognitive therapy, occupational therapy, to be able to indeed add years to life. First of all, assess, evaluate, set goals, intervene, and reassess again and readjust the goal as may be required. Add years to life to years, meaning to life, which is the purpose of rehabilitation across the two different phases, which is neuroplasticity by strengthening neuroplasticity or modifying or modulating that, and the adaptive aspects, which is psychospiritual. Some of this has been alluded to already by Professor Volker Humbach. So, well, the world is actually looking at ensuring that people with disabilities are able to access rehabilitation services by 2030, a call for action by the WHO. But there's the LMIC conundrum, which needs to be dealt with, whereby most of the burden is in LMIC is more than 80–90% of the burden, and less than 10% of the resources in terms of personnel and other resources are in LMIC. And that is really a dilemma. And that's why perhaps community-based and family-based, rehabilitation may mitigate in terms of task shifting and task sharing. And it's also important to integrate rehabilitation in the entire continuum of care, and perhaps have some specific approaches to certain diseases which are leading, like stroke, as well as traumatic brain and spinal cord injuries. So the WHO came up with a package of interventions for rehabilitations, which was launched just last year. Now, looking at the global south and global north, you will see that the expenditure for health, including rehabilitation, is very lean in the southern hemisphere, and whereas they bear most of the burden. So what do we do? And most of payments, 80–90% of payments are out of pocket payments. And to make matters worse, there is massive brain drain going on after COVID, which is depleting the health and human resources, particularly from LMICs. So if our goal is to improve health-related quality of life through affordable, accessible, effective, appropriate interventions, how do we have an economically sustainable model? If we want to reduce the price, you have to increase supply and reduce demand. But the challenge is that actually in LMICs, the demand is not as high as it should be because people are not even aware about neurorehabilitation. The awareness is just beginning to build up. and the promises and possibilities of neurorehabilitation, people are not that much aware. So we really actually have to increase the demand as at the same time also increase supply. We need to promote affordable and accessible pragmatic solutions, low cost, some of which has been mentioned by Professor Volker Humberg, including the forced use therapy, pragmatic implementation science, and of course, task shifting, task sharing. And this is where combining family-based, caregiver supported or supported caregiver, community-based, tele-rehab, combining this may actually be the solution. In the meantime, while we need to really massively train a whole army, so to speak, of rehabilitation experts and therapists in LMICs by working with training institutions across these countries. Community reintegration is very important to work and employment, and of course, the rights of people living with neurological conditions also needs to be respected. At the end, we want to promote brain capital, which is central to human capital, which is central to development. So this shows the arrangement, the matrix, so to speak, of the different care settings for neurorehabilitation for those who have suffered neurological injury. There is acute care, there is subacute rehab, there is community-based or home-based or tele-rehab. Of course, there is also outpatient and special subacute rehab facility. And we also have to think about long-term sustained rehabilitation, which is lifelong. So acute care, subacute, outpatient. And again, this is a bidirectional model, in which case people receive acute care and they can then get to the next stage, which is subacute rehabilitation, and then outpatient rehabilitation, and then eventually step down to home-based or community-based rehabilitation. But if they have comorbidities or other reasons why they still need some support in terms of outpatient care, that is also important. Of course, we also have to think about long-term sustained rehabilitation. Now, just to quickly mention a little bit about this before I go into details about it. Now, home-based care can be delivered by caregivers, but we have to bear in mind caregiver burden, caregiver stress, anxiety, depression, that's very important. And so caregivers may actually need a lot of support before they can give some form of informal therapy to improve the intensity, content, and duration of therapy that is required for the improvement in quality of life and in functional outcomes. So this is important. Now, the other way by which home-based or community-based rehabilitation can take place is if we have trained people, experts, therapists, physiotherapists, psychotherapists, and so on, who go to the houses to deliver these services, or go to the communities to deliver these services to a group of people in those communities who require such services. But this may be expensive, perhaps even more expensive than for the patients to come to the outpatient facility for care. So this has to really be discussed. But if it is task shifted to maybe family members or caregivers or primary healthcare workers who are trained to deliver some level of care, this may work. And this is actually one of the things we are trying to do in Africa as an example. So the clinical pathways in neurorehabilitation discusses all these healthcare settings for rehabilitation after stroke in detail. Now, community-based rehabilitation is actually not new. WHO has been talking about this since 1970, but it's gaining more momentum as the WHO is pushing the agenda of WHO Rehabilitation 2030. So community-based rehabilitation is multi-sectoral and is essentially ensuring that rehabilitation services are made available to those who need it, including provision of long-term care, preventing causes of disabilities, and then monitoring and evaluation to ensure that people have access, they have support, love, and care, and they are fully reintegrated into the communities. So that's what community-based rehabilitation is all about, to ensure that the services are delivered and that community reintegration is also part of it, and people can go back to family life, go back to recreation, as well as work. So essentially, it's a strategy for improving the quality of life of people with disabilities by changing the work of the various services for people with disabilities in order to best meet their needs, ensure their equal opportunities, and protect their rights. So why is this important? Of course, we already mentioned because as a stopgap, because we really don't have the personnel that is required. In fact, to make the figures even more scary, so to speak, in Nigeria, there are about 75,000 doctors who are trained in Nigeria, physicians. More than half of those have emigrated from Nigeria. So we have only about 30,000 doctors to a population of 220, 230 million people. And that's 1 to 10,000 the population ratio for doctors, not to talk of rehabilitation experts or neurologists, which is even worse. So goals of community-based rehabilitation to ensure that people with disabilities are seen as able, not as disabled, maximize their physical and mental abilities, improve access, enable them to become active contributors in society, essentially. Respect for and acceptance of people with disabilities is important. If the community is actually taking care of them, that ensures that it's done and that they have equal opportunities and that they are empowered. So the CBR matrix includes looking at different sectors, the health sector, the education sector, livelihood, social, as well as empowerment. We can't go into details about this, but they're all very, very important. So it's a multi-sectoral nature of community-based rehabilitation, which makes it even better than the hospital-based model, because there's really integration uh, into the community. So again, people live in communities at the end of the day. So therefore, 24-hour access to community-based rehabilitation is feasible. Community-based level, is like at the base of the pyramid, and that's where people live and their families, and then of course communities. And you want to make these rehabilitation services as close to them as possible by involving local authorities, community leaders, and so on and so forth, and national government. Now let's illustrate with stroke. The Lancet Commission for Stroke was launched last year. Uh, uh, the work covered more than 84 countries, more than 322 commissioners, and more than 200 co-authors. So essentially, surveillance, prevention, acute care, and rehabilitation. So what do we have to say about neurorehabilitation of stroke? We came up with this uh, theory-based intervention implementation science model about stroke control that includes capacity, capability, opportunity, and motivation. And guidelines are important, but they're only just part of the piece of the puzzle. There are other things, including service provision, which is what we are discussing today, legislation to improve the rights of people with disabilities. So that's very important. So what are the key messages for it? Has to be multidisciplinary, and then innovative low-cost interventions, training of stroke rehabilitation professionals across the globe due to the huge and massive shortage, use of assessment tools like quality of life skills to ensure that patients are actually getting better. Telemedicine, digital channels are things that are to be leveraged for telerehabilitation to improve access, and training videos and so on and so forth. Now, multidisciplinary characterization of the life course, that's research priorities to help us understand better the evolution of the different aspects of life and livelihood after stroke and other neurological disabilities. And of course, development of tailored rehabilitation protocols for low and middle income settings. Validation of the effectiveness of educational tools for rehabilitation, including tele-rehabilitation, training videos, mobile health, investigating the feasibility, safety, effectiveness, and coverage of home-based rehabilitation. The ATTEMPT trial attempted to do this, but we can do even another trial or other trials to really see how this can be done. And also community-based rehabilitation, investment in regenerative medicine, novel medications to modify neuroplasticity, low-cost and accessible robotics, neuromodulation tools, brain-computer interfaces, gaming, and novel biomarkers for prognostication. So these are all very important. Family is important. I'm sure that Nyama Suya is going to talk about this. I've got this slide from him. Now, community-based rehabilitation, should they be delivered by specialists or paraprofessionals? Specialists is going to be expensive. Paraprofessionals may not be able to deliver sophisticated care, but maybe some level of care under supervision. But they are more integrated into the society, and they might be able to provide even more support. Community members are very important to provide support in community-based rehabilitation. Civil societies and the relatives organizations also have a role to play. Policymakers also have roles to play. So family trainers, coordinators, superintendents, people with functional limitations, we need to work with family trainers, caregiver, coordinators, superintendent, and rehabilitation committee for community-based rehabilitation to really work, including the community-based rehabilitation staff, and so on and so forth. So for CBR to work, we need to make multidisciplinary therapy accessible at the community level through task shifting or task sharing. Teleservices may also help in some instances. We need to research into low-cost, effective, pragmatic solutions that can be delivered, including locally produced assistive devices that can be delivered at the community level. We need to enlighten people and educate the family and caregivers. Advocacy for instance, we are leading the domestication of the WHO Intersectoral Global Action Plan for neurorehabilitation and other interventions for neurological conditions in Africa for the WHO Afro region. We've written a report which is going to be launched very soon, and we'll then work with the Ministries of Health after that. Trainings, very important, webinars, workshops, and we've done quite a number of these, including right now, as we speak, there is an ongoing robotics training going on in Ghana by SASNet and ICRA. So rehabilitation services from the Lancet Commission, we found particularly for stroke to be the least attended to across different world regions, including in sub-Saharan Africa, where only about a quarter of people who need these services and who are getting other stroke care services are getting that. So primary healthcare based, which is community-based services, we've shown that this is feasible in Africa. And same thing with delivering physiotherapy at the place of domicile. Both of them are feasible and also effective. So it's important to have a global ecosystem in engaging policymakers, patients, payers, general population, providers, implementation partners, and ambassadors to be able to drive the agenda of community-based rehabilitation. So we started the African Stroke Organization to drive this agenda, at least for stroke. These are some of the activities that we've had in the African continent to promote neurorehabilitation services generally, including community-based rehabilitation. SANRA, the Restore program, this was in Egypt, and several programs which took place in Nigeria, including training programs. That's the Blossom Center, and that was the NFNR conference of 2022. The African Stroke Organization, 2023, actually, we had quite a number of conferences. The African Stroke Organization conference, the African Congress for Neurorehabilitation, and we have training programs, talents, grasp, for those who are interested in neuroscience and use of data science to improve neuroscience. And we had the 5th African Congress on Neurorehabilitation. Part of what we discussed, of course, was community-based rehabilitation, precision medicine, neurocognitive psychology, aphasia, post-stroke gate rehabilitation, brain health, wearable technologies, neurophysiotherapy, and so on and so forth. And SAFNA, this just happened in February. And we do hope to host the World Congress on Rehabilitation in 2028 in South Africa, where I am right now. I'm actually speaking from South Africa. This is going on right now in Ghana as we speak. So hopefully we'll be able to work with the rest of the world and other implementation partners and support groups across the globe to ensure that by 2030, most people who require neurorehabilitation services are able to get them even on the African continent. So the wind of change is blowing to Africa. This was in 2007. Mapping Africa's way into prominence in the field of neurology. This was when I just returned from Germany and got integrated into the services in Nigeria. And this was published in Archives of Neurology and was accompanied by this editorial by the then president of the World Federation of Neurology, at Nose Inc. Alai CTNTs Ibimus Afros. The wind of change is blowing, and Africa is going to be part of it, and we ensure that people living with neurological disabilities are able to get care and are able to live a good and fulfilled life. Thank you very much.
Yeah, thank you very much, Mayowa. That was a very, very good tour d'horizon to all these aspects of community-based rehabilitation, which we believe is one of the key future procedures we have to use. Let me just give a short comments to the audience. If you have any questions, just use the Q&A mark or the chat room so that we can fuel that into the later discussion. I think what is absolutely clear from Mayowa's talk basically is that we, in some sense, have to change our minds. We cannot adhere to the classical concepts of neurological rehabilitation, especially when it comes to low-middle-income countries, serving millions and millions of people who otherwise will not have access. So we have to find new strategies, and technology may, in some sense, at least digital communication technologies, may certainly be very helpful in doing that. So please use the chat function and the question answer section so that we can fuel that in the discussion later on. Mayowa, thank you very much indeed again. And if you allow me, we go for the next speaker, which I think is Professor Surya from India. He is the regional vice president for the region in South Asia and especially India. And he is for many, many years working with the World Federation of Neurorehabilitation. He was the convener of our World Congress in Mumbai, India, a couple of years ago. And he is not only an expert in neuro rehab, he's also an expert in epilepsy. And I think what he's going to talk about today are aspects of epilepsy around the world. So thank you very much. Nirmal, where is he? Nirmal is lost. Christian, do we have contact in Nirmal? Okay, obviously we lost the contact for a moment. He was in some minutes ago. So we go for just for the sake of time for originally the final speaker, but we do it in between. Professor Caterina Pistolini from Italy. She's the Secretary General of the World Federation. She's an expert in all sorts of modern techniques in the field of neurorehabilitation, and she will talk about the possible influence of brain-computer interfaces. So,
thank you so much. Sorry, some time to share my screen. Can you see? Can you see?
Yes, we can. It
you
was
can?
Good. Yes.
Okay. Thank you so much. Now we talk about...
You have to restart the share screen, Professor Pistarini, because you closed it.
Okay.
So once more.
Okay, sorry. Why? Can you see? Can you see now?
Okay. Yes, it's okay. Yeah.
Thank you so much. Now we talk about the brain-computer interface as a tool for neurorehabilitation. But the second title of my presentation is how the advanced technology can be a chance for neurorehabilitation. And a first step is to analyze the current situation nowadays. We face aging population with long-term illness. Promptly diagnosed, even if not curable, that accompany people for many years of their life, that determine disability and self-sufficient conditions lost, and that determine social fragility of patients and his family. We know that only 20% of patients fully recover their social life and job activity after neurological injury. And the traditional neurorehabilitation procedure may have limited efficacy in most patients with common neurological diseases, such as Parkinson's disease, stroke, spinal cord injury, severe brain injury, and other cognitive and motor disorders. Hence, there is a need to find a new approach in rehabilitation to maximize the functional outcome of patients, to improve patient quality of life. New technology is a growing field, and modern technology represents one of the most recent advances in neurorehabilitation. The use of health enabling technology is one of the important means to face some challenges linked to demographic change with respect to risk of multimorbidity and increased need from patients. Now, from big robotic machine to small wearable device, new technology can deliver different therapy goals and within a different type of rehabilitation facility. But the choice of which technology to use can be overwhelming. And how we choose and why we choose brain-computer interface in this presentation. Because brain-computer interface appear a new assistive tool as a system that decode brain signals generated in the brain of patients to user-specific command on an external device. And since the electroencephalography has been applied on humans, there has been much speculation about the possibility to translate thought of patients in external command and to control external device. From 1980 to 1990, we had an increasing number of work about the use of computer interface. As you can see from 2 publications before 1993, we arrived in the recent year to more than 400 work, in particular in rehabilitation. And then in this presentation, I would show you some aspect, in particular a technical aspect of a BCI system, the application of a BCI system in rehabilitation, and 2 examples on the use of BCI on stroke patients and in disorders of consciousness patients. This is a general framework of brain-computer interface. The stimuli induce some change in the activity of primary sensory motor area of the brain, and this can be recorded by invasive method with implanted sensor or non-invasive method, for example, by fMRI, but in particular by EEG. The amplifier records the signals, and a specific algorithm translate the signals and extract the signals more helpful as output to translate the intention of patients in external command. The aspect of algorithm is a very important aspect, because in the era of artificial intelligence, where the algorithms are studied to manage many data on patients, this is one of the methods that at first translate brain signals in external command and allow to to understand and integrate the link between a brain network and the part of body. One of the main aspect and one of the paradigm is the motor imagery. Motor imagery can be defined as a state, dynamic state during which given action is mentally simulated by subject. This process is helpful not only for learning a motor skill, but also to improve the movement itself and to make the movement more effective. The subject can implement two different techniques. First-person perspective, if a patient imagines himself to perform the act, and in third person, the subject as external person imagine himself to perform the act. And it is confirmed that mental imagery improve the rehabilitation, especially if this mental repetition precede the motor exercise. And the motor advantages is that the mental recall of motor task allow patient to increase the number of repetition safely, independently, and with less physical fatigue. And then motor imagery is used in patients with neurological disability, neurological damage, to enhance cerebral plasticity and to activate cerebral plasticity, but also this method is used commonly in some sport to improve the skill of person, of men and women. And a very important factor is for the functioning of a brain-computer interface is the integrity of subcortical structure, because they address the mental representation of the motor act, because attention, working memory, and ability to construct and recognize and transform images is very important, and then it is very important the integrity of basic imaging process in patients. Then we have two ways to use a brain-computer interface in rehabilitation. One way is to use a brain-computer interface as assistive tool, for example, to replace the motor function or communication, and brain-computer interface system aim to substitute this lost function. For example, with the robotic device to replace motor function lost by stroke in the arm or in the leg. But a very interesting process and that improve the use, the motor function or communicative function is the ability of patients to self-regulate or manipulate his neurophysiological activity, is cerebral rhythm with the BCI system. And this is a very interesting use of BCI in rehabilitation. Another aspect is to say about the link of BCI and neuroprosthetic. Frequently, the two terms are mixed, but the difference is that BCI typically connect the brain with a computer system, brain or nervous system. Neuroprosthetic typically connect the nervous system to a device. And in the recent year, the new tool of research and the new aim, the new objective of research is to connect the prosthesis, for example, in amputee patients, with the PCI system, then to establish a connection between BCI system and neuroprosthesis. Then some aspect linked to the use of BCI in rehabilitation. As you know, the basis, the paradigm of rehabilitation is the cortical reorganization. And some studies have demonstrated that the differentiation of a body part induce a reduction of this body part representation in the sensory-motor complex. And when the physical exercise is no longer possible, motor imagery may be only the possible way to train the motor system. And then motor imagery is also one of the paradigm of BCI. Then BCI itself is a candidate for rehabilitation tool in case of cerebral damage. And for stroke recovery, you know that we have 3 phases. The first phase is a reduction in edema. Functional recovery is a compensation and based on improved use of remaining motor function. And real is the restoration of brain function due to homeostatic and learning-dependent reorganization of the brain. BCI provide a channel for using brain signals to control or to command an external device without the use of peripheral nerves. And this is an example. I try to show you. This is a constraint therapy. Patients guided by physiotherapists with the system of BCI and by manipulation of self-regulation cerebral rhythm try to move the virtual hand. This improves also the cerebral reorganization and then to enhance the reorganization of cortical area damaged by lesion. We have many studies about. This is the first review that investigate the possibility to enhance BCI performance using both physical movement, as happened during the standard rehabilitation, and the motor imagery with the rhythm, mum rhythm, and beta rhythm that are the rhythm of mental imagery. And in this slide, you can see some work on stroke, where the use of motor imagery is and the motor movement execution is coupled with BCI and physiotherapy. But another important review is this one published on 2021, where brain-computer interface demonstrated in the study collected exciting results in providing cognitive and physical support and rehabilitation. And then the authors address the researcher to this important area that can be a new strategy for neurorehabilitation in patients with neurological disability. Another aspect of BCI and another new frontier in the use of technology is to combine BCI and robot therapy. In the last 3 years, we have some study about, and robot use are represented by end effectors. Which is the strategy? The strategy is that excitation of perilesional area during the repetition of the task with the robot therapy, we can create a closed loop between robot therapy, robot and BCI that can enhance the plastic change in the brain during rehabilitation training. And in this last review published in 2021, among the 30 studies, 19 stress the importance of combining BCI and robot therapy. And but this review outlined the extreme heterogeneity in the report. Then this review stress the need to establish and to develop standard protocols for assessing technical and clinical outcome and to provide evidence on efficiency and efficacy of treatment. I would to mention a very interesting aspect of BCI based on potential related to cognitive perceptual event, the well-known P300 wave that is one of the paradigm of the BCI, and then BCI could be used for cognitive rehabilitation. There are substantial evidence on efficacy of cognitive therapy concerning stroke and traumatic brain injury. And in cognitive rehabilitation, the use of event-related potential is limited on assessment, but we can enhance and you can use this strategy linked to BCI to improve some cognitive performance, and in some cases also to improve the communication ability, where patients, in this case the BCI is not outlined, but can communicate with computer some word on external examiner. And we have a lot of work in the last year about the use of BCI in cognitive rehabilitation. These are some of them. And to conclude this overview on BCI, I would only to mention the first work published in 2012 on the use of brain-computer interface to improve communication in non-responsive patients, in particular patients with a diagnosis of vegetative state and minimal conscious state. These patients have a very big and severe brain damage, and the possibility to detect the brain signal have been some technical aspect have been used, some technical method have been used, for example, fMRI, but EEG seem to be the best because non-invasive, portable, and that offer the possibility to repeat the exam over time in the same day also. And in this work, that is a very well-known work published in 2006 by Adrian Howitt, the authors tried to explore if some activity in the brain of severe brain injury patients was preserved. And they established to tried to improve the ability of patient to follow some command and to establish some sort of communication in two different steps. The first step, establish successful common following, and the second step, to try and establish the communication. Of course, the severe deficit in language comprehension, decision-making, working memory, and several cognitive ability are impaired in these patients. Then it is difficult to try to establish how we can to use some sophisticated method such as BCI. but in the last work, some different aspect of a severe brain injury emerge. And all the ability are not white and black, but there are some aspects defined gray aspect that can be observed. Many investigation can be necessary to establish the performance of patients. But in this condition that is named cover consciousness, we can consider BCI and to try a personalized therapy to assess patients and in particular to assess and to treat pain. This has been well established in this work published in 2021. Then we need to understand the complexity and interaction between patients and new technology intervention. This facilitate the informed decision and improve patient outcome. And the scientific community is finally showing an effort in this direction. Take in mind one aspect that had been outlined by Professor Homberg in his introduction. All our treatment have to be personalized. And this is exactly the direction we should be undertaking in neurorehabilitation. Then a lot of work has been done, but a lot of work has to be done. Thank you so much for your kind attention.
Okay, thank you very much, Katerina, for this very, very nice review on the chances, risks, perspectives of brain-computer interfaces and the technology involved in that, not only for prosthetic use, but also eventually to help facilitate brain recovery, which I think is a very charming aspect of brain-computer interfaces, to mention, except the prosthetic use, which of course is straightforward. Yeah. Okay, so back to the audience, please use the question and answer and the chat room so that we can collect some nasty questions or comments or whatever. And nevertheless, for the time being, we go on with our final speaker. It's my very good pleasure to welcome dear friend Nirmal Surya from Mumbai, India. He is the regional vice president for the WFNR in the India and South Asian region, and for many, many years he has been an extremely good and fruitful partner to us in almost every respect. He organized the World Congress of Neurorehab some years ago in Mumbai, and even before and ever since we have been in a very, very close cooperation. And he's not only an expert, as I mentioned already, in neurorehab, he's also an expert in epilepsy, and I'm very glad that he agreed to speak about epilepsy problems today. Thanks very much, Nirmal, for coming, and the floor is yours.
Dear Mr. President, very kind of you to introduce me wonderfully. Thank you so very much. And Christian, if I can share my slide. Okay. Is that visible, Christian?
Yes, it is.
Yes, it is definitely. No, it is. Yeah.
All right. Thank you very much, sir. And a lot of people of you must be thinking that what is the connection in epilepsy and neurorehabilitation? And I'm going to show us that what in India, how the rehab team works hand in hand with neurologists to deal with the epilepsy and neurodisability. So as you know that India is the most populous country in the world, 1.42 billion people in India. So approximately now 14 million people have the epilepsy. And this is a old data, which is one of my friend has shared. I represent Epilepsy Foundation of India, which is a NGO working for the people with epilepsy, and we are the associate chapter of IBE, International Bureau of Epilepsy. You all know that epilepsy is a disease of the brain defined by either of the following: at least 2 unprovoked or reflex seizures occurring 24 hours apart, or 1 unprovoked or reflex seizure and a probability of further seizure similar to the general recurrence risk, that is about 60%, and 2 unprovoked seizure occurring over the next 10 years. So diagnosis of epilepsy syndrome become easy in this situation. We know that there are 70 million people suffering from epilepsy worldwide. Nearly 85 to 90% of those are living in the developing countries. There is a lower prevalence of active epilepsy in industrialized country than the developing country, and which could be because of low prevalence of selected risk factors, more infections and trauma, more stringent case verification, and exclusion of provoked and unprovoked isolated seizure. In India in particular, the rural area, the labor and the delivery used to happen in the home, in the villages, and therefore the child trauma and hypoxia also is one of the major cause of disability and epilepsy. These are the global incidence of active epilepsy. And again, as I mentioned, higher in the low-income countries as compared to the other. And if we look at epilepsy in Asia, the highest incidence being reported from the Turkey between 7 and 12. India is a couple of reports between 3 and 11.9. And then, of course, China, the Saudi Arabia, Thailand, Bangladesh, and other countries. So there are certain countries where data are not available, but this shows that there is a high prevalence and incidence of epilepsy. We look at the causes of epilepsy. There can be multiple etiology, and in some cases it may be multiple, means like tuberculosis. You have a genetic background, but you also have tuber, which are the structural problem. So structural abnormalities could be, due to trauma, stroke, infection, tumor, genetic malformation, or cortical dysplasia. But 85% patient, you may not know the cause. Immune-mediated epilepsy is also known, which causes CNS vasculitis. Then, of course, is genetic, which is inherited, or it could even be de novo. Infection more likely in developing countries, brain encephalitis, tuberculosis, malaria, Zika, and metabolic encephalopathies. Like childhood, there may be vitamin deficiency, hypoglycemia, which are much more common causes. The management of epilepsy is, again, it is a heterogeneous disorder, multifactor origin and manifestation. There's a management required, the complex consideration. There are more than 25 drugs are available at the moment. Although rates vary in individual study, approximately 70% of patients, new onset, single or monotherapy can be easily achieved the seizure freedom. And there are about 1/3 patient which may be drug resistant. If you look at the various anti-epileptic drugs, these are the older anti-epileptic drugs started with bromide in 1860, phenobarbital, phenytoin, carbamazepine, valproate, which are the first line of the drug, which we used to call. And now, if you look at the newer drugs, the cannabinoid, brevacticitab, retigabine, and lacosamide, rufinamide, stiripentol, levetiracetam, oxcarbazepine. So the list has been, in past 20 years, the list has been increasing. The newer drugs are less side effect, more tolerability, and more effective. So management is primarily focused on efficacy, safety and tolerability, and spectrum of activity. So different mechanisms, sodium channel, potassium channel, calcium channel, AMPA receptor, or the GABA. So depending on, or SP20. So depending on these, there can be a selection of the drug. Ideally, epilepsy treatment would lead to no seizure, no side effect. This is difficult or impossible to achieve at this point of time, but it may require decision tailored for each individual. It may not be true 20 years or 10 years later the time when you will have a genomic, pharmacogenomic, which will determine what drug you are going to respond. There can be combination use if the patient do not respond to monotherapy, and you have certain good combination like valproate with lamotrigine, valproate with carbamazepine is not a very good combination, but phenytoin and phenobarbital is a combination very often used in country like India, in Africa, in the remote places, and because they are cheap and effective. Lamotrigine, topiramate, lacosamide, and levetiracetam, valproate and levetiracetam. So these are the combination which can be used effectively in various kind of epilepsy. If you look at the long-term outcome to the anti-epileptic drug, you know that with monotherapy, one of these papers shows from 1144 patients, 55% seizure-free on monotherapy. There are another 8% with the two anti-epileptic, and 37% patients were not seizure-free in spite of these two. The various reports says that 70 to 80% of patients newly diagnosed eventually achieve remission, with majority achieve within 2 years. However, the treatment gap in various parts of the developing countries from 50 to 90% for various factors. And one of the longitudinal study from West Bengal reported that 43% of the patient discontinued their treatment within 1 year after initiation. And this is another problem which is rather prevalent in rural area. And the reason for discontinue were financial overburden in 90%, unemployed in 29%, frustration and despair that how long I will need to take a medicine, 20%, 21%, non-availability of medicine locally is 20%, and superstitious about the epilepsy in about 17%. So these are the various causes which are relevant in the country like India. So how do we have the strategy individualized for the epilepsy? So we need to look at the comorbidity, drug-drug interaction. We need to look at special population like women, pregnant women, the elderly, the newborn, ease of use. So once a day versus twice a day, epilepsy syndrome. Seizure type is important because that's how you select the medicine, patient lifestyle characteristic preferences. So these are the things which we need to look into. There is a SUDAP which shows that sudden unexpected death in epilepsy, and with the incidence of 1.2 per 1,000 population in the age of 20 to 40, particularly those are not well controlled on multiple drugs, and there are certain risk factors like GTC, increased seizure frequency, concomitant LD, and SUDAP is higher in epilepsy patient receiving placebo versus patient receiving active treatment. And we really need to optimize the treatment and under the supervision. So what is the impact of epilepsy patients' life? And this is where the neurorehabilitation comes in, because stigma in epilepsy give rise to depression, neuropsychiatric feature, and increased anxiety level. There is a lower rate of marriage, reduced probability of employment, lower income, and lower educational attainment. And that leads to further depression, neuropsychiatric symptoms. So stigma is a common feature of epilepsy in both developed and developing country, and is one of the most important factor with a negative influence on people with epilepsy. So what is our experience? Our NGO is the only NGO in this country to work with the Government of India, National Health Mission in term with Government of Maharashtra, Health Ministry. And we have developed this model with a public-private partnership over last 14, 13 years, which is we organize epilepsy detection and management camp. We have online data system. And you see here, beside neurologists, pediatric neurologists, pediatrician, EEG technician, we have physiotherapy, speech therapy, occupational therapy, counselor, and social worker who are part of the team which we provide free EEG, CME training, audiovisual, and others sensitization of the things. And the government provides us the infrastructure, coordinator, patients, nurses, blood tests, MRI, CT scan. So all that is available to us. And this is the first pilot study which we did, organization of epilepsy camp with the help of Epilepsy Foundation. And this was a funding from Government of India. And we did this 7 camps to start with. And it worked. But we had a lot of issue in that, which we covered. And over a period of time, our public-private partnership with National Health Mission has been going on well. We are now establishing the Regional Epilepsy Center. The more funding is available to us because each and every patient who comes in the camp has been given 3 months medication free. And these drugs include levetiracetam, oxcarbazepine, clobazam, lamotrigine, topiramate, etc., etc. So patients are tremendously benefited. And by now, we have about 35,000 patients seen over a period of 13 years with 104 camps. 4,700 EEGs are done. Counseling of 2,661 patients. Physiotherapy treated 2,483 patients. OT treated 3,808 patients. And same was the speech therapy. Nearly 3,400 patients were treated by them in the camp with the follow-up through the telemedicine. These are various camps and their data. So I always say that epilepsy is a concern to us because it has a hidden disability, because it affects all ages, child, parent, adolescent growing up with epilepsy, a different problem. Adult with epilepsy, more trouble. Elderly people, different issue. Alone, dependent, spouse, they have another issue. Caregiving, there again they get depression, caregiver burden. If you look, mother with epilepsy, late onset versus early onset. So every type of patient or the group has a different issue. So illiterate rural dweller, overtly God-fearing, blaming epilepsy as a curse. They accept the disease and do nothing, do not even take medicine. Literate urban dweller, but not so different need, stigma and poor attitude, run from pillar to post with no solution. Taboos and catastrophe of patients who are seizure-free post-op find difficult to accept normalcy. Family expectations are very high, and as they have new life, still clinging to the past. So adjustment is another issue which needs to be taken care. So this is what is we are looking at. Epilepsy without disability, they are treated with monotherapy and they go on as a follow-up to the neurology. But epilepsy with disability is physical disability, speech and swallowing disability, learning disability, cognitive disability, psychosocial disability, memory disturbance, behavioral disturbance, ADHD, autism. So these are the problems which are not exposed because patient has epilepsy and the neurologists are only concerned with the controlling the seizure, providing medicine, more medicine, and these all are goes onto the sideline. So that is what is really happening. So in the camps, what we are providing is a multidisciplinary team which look after the patient who need us the most. And I share a few of the data. I'm not sharing everything. We know that 20 to 30 of patients with epilepsy have psychiatric illness. There can be intractable partial seizures, which can have 70% or more have more than one DSM-3R diagnosis, and 58% may have a depression episode, 32 may have agoraphobia or with panic or without panic, anxiety disorder, and 13% may have psychosis. So risk of psychosis in patients with epilepsy 6 to 12 times higher than general population, with a prevalence of about 7 to 8% with refractory temporal lobe epilepsy. So these are alarming features. So if you look at the data available, so you have major depression, control is 10.47%, but patient with epilepsy 17%. Anxiety is almost double. Mood and anxiety disorder is again 34%. Suicidal tendency double, and others are double. So nearly all the psychiatric comorbidity in epilepsy are double than the normal population. We have evaluated nearly 1,876 patients, out of which 846 were adult during the camp, and among these 846, 778 were patients with epilepsy. And if you look at the major psychiatric comorbidity, depression was seen 67%, anxiety in 29%, psychosis in 11%, intellectual disability in 29%, suicidal ideation in 35%, and pseudo-seizure in 8%. And 42% patients were on AED, with 65% of adults with uncontrolled epilepsy. So these are alarming figures from the rural area. So psychiatric comorbidity in adults were underestimated, leading to poor quality of life and increase in seizure. 91% psychiatric comorbidity are from mild to severe level. Comorbidity have a significant impact on quality of life, compliance, seizure frequency, and the cognitive function, critical to treat psychiatric problem for better health-related outcomes. And we also did quality of life poly 10 for 238 patients with epilepsy, and we took the consent. We observed them with the treatment three months, and first we took at baseline and at the 3 months, and interim result shows that baseline 3 months and 6 months. So they worsen because of social limitations, seizure work limitation, and psychological problem. With the help of team approach, patients are improved on seizure worry, social limitation, medication problems, psychiatric and cognitive problems in 3 months and 6 months. And you could see that controlled and uncontrolled patients in 6 months. Those who are controlled, they did better. And quality of life has definitely improved for a 6-month period of time when we have followed them with the treatment. They improved in 3 months, and they continue to maintain at 6 months time. So treatment is very important. These are some of the papers which we have presented. So these are real world study of efficacy in the epilepsy, and this is our counselor who's present most of the camps. And these are the before enrollment, post 6 months, post 1 year, post 4 years. So we have data right going up to the 4 years. And these are 72% who have evaluated. 53% male, 43% female. And duration of epilepsy is more than 30 years, 8%, 21 to 30, 19%, 11 to 20, 26%, and less than 10 years is 20%. In last 4 years, 64% of patients complete seizure freedom. And this give rise to the comprehensive approach provided by Epilepsy Foundation. The quality of life which will improve. The free medication provided to them is something which is a game changer, because availability of free medicine has made a lot of difference to their life, and they continue to take treatment. We also had the neuropsychologist who work on the cognitive impairment of the patient using the brain next tool, which is a tool which has been used for the people with sensory information, loss of recurrent seizure, bilateral epilepsy involving the corpus callosum. Cognitive rehabilitation was planned with that synaptic plasticity. And this is one of the patients. These are A, B, C, the male person with uncontrolled epilepsy, 11 to 17 years. And with that, over a period of time, in 5 months, the progress was measured as 10% to 10 at 100% with a scale of 0% as baseline. We presented this paper also, that recovering cognitive deficiency in epilepsy through the brain next tool in people with epilepsy. And these are 146 patients who have been treated, male 66 and female 18. Age was from 2.6 to 45 years, and duration of treatment was 19. And so from baseline 0 and deficit, they improve significantly in 0 to 9 months. So 1 year follow-up is still pending, and we'll do that. So these are the results which has been shown, and it shows that if a patient has been treated continuously over a period of time, this is pre-COVID, post-COVID, we continue online therapy with this patient. Comprehensive epilepsy care during the COVID pandemic was something which we did. We created a model, and this is the model which is there. We have evaluation, no seizure, then the counseling for COVID, and if the patient COVID suspected, then they go into the COVID ward, and then the severe, the patient evaluated. If the anti-epileptic drug is there or not there, change it. If the patient has associated disability, then they will have online counseling, occupational therapy, physiotherapy, speech therapy, and cognitive therapy. We also assess quality of life for people with epilepsy in COVID, and These are the no seizure, 69% patient. Again, we provided free medication to them. 1 seizure, less than 1 seizure, more than 1 seizure. And these are the seizure due to the missed doses. And there are some seizure because of stress, 8%. And you see the overall quality of life. And these are the activity of daily living, mental activities, medication effect. So most of the patient, when we asked during the COVID, which is the most concerning point from the people with epilepsy perspective, we got a mixed bag. The most concern point raised by people is medication effect, followed by seizure worry, and overall quality of life as soon.
Good morning. I'm Dr.
We have long-term outcome of epilepsy camp. We presented in the American Academy of Neurology. We also survey the patients during the camp, and this was about 15 questionnaire which we asked the patients about the awareness and knowledge on the epilepsy. And we have nearly 11,000 patients data, and which shows that there's a great need of creating awareness in rural India. And this is the paper which we presented, and this is a questionnaire survey which for the ASHAs. So among the patient also the knowledge was poor, but even the ASHAs, they're better than patient, but still yet it is ranging between 60% to 80%. And we really have trained ASHAs for last 3 years, taking their lectures regularly to wear them. Now, what has we done with all this? With all this, what has happened is when we started the camp, the Maharashtra, the treatment gap was 78%. And by providing this therapy, regular medicine, following them up regularly, we have been able to bring it down. And I'll show you in the next few slides what we do in post-camp follow-up activity. We gather all the data. We have a monthly telephonic follow-up. We have incoming support via telephone and WhatsApp. And appropriate patient were referred back to civil hospital or the district hospital or free epilepsy clinic. So patient facing difficulty in getting medicine, we deliver them at home through the courier services. So what we have done, around 1,000 calls, this all again before pre-COVID, we started nearly 1,000 calls per month to these patients. This is the team who will call. These are the nurses who work as a call center. And if you see that 77% first time they were adherent to medicine, which improved in a month when we call them up. But there are nearly 9% patient, 9 or 10, 20% patient who would not take medicines, which with the constant calling, the seizure freedom improved from 68% to nearly 74%. This was the first part. And the side effect was about for 10%, but they were not major. We do the scanning, which take 30 seconds in camp. And patient send the medicine, patient send their photograph, and they are on WhatsApp, they start sending the problem. So if you look at this data, we continue to call right up to the April 19 every month and see the 72% patient was seizure-free. So treatment gap from 78% has dropped down to 27.4% for a period of with the regular treatment. And you can also see that persisted. So nearly 76% persisted. 84% patient claimed total adherence to treatment, while 15%. So that adherence improved because of availability of medicine. 86% did not report any side effect. And whatever the side effect was, depression, nausea, headache, drowsiness. So not a major side effect was reported. And we also asked them, what is your feedback? How satisfied you are with the calling services from the Epilepsy Foundation? And you could see most of them were excellent or good. So this has helped them achieve this. These are my inspiration, my parents and mother trees. So to summarize, epilepsy is a common and serious neurological disorder characterized by predisposition of brain to genetic recurrent seizures. It affects childhood, adolescent, and elderly. The most common are between children and the adult. Worldwide prevalence is 4 to 8%. It can have structural, immune, metabolic, genetic infection of unknown origin. It's a public health problem and substantial impact on patients' life with poor quality of quality of life have to face stigma. Quality of life is bad. Comorbidity in epilepsy is common, and epilepsy is associated with increased risk of premature death, which is SUDEP, and there are significant direct and indirect costs associated with epilepsy. Disability is hidden, and that has to be looked into once the patient is on anti-epileptic drug, which may be because of epilepsy itself, associated comorbidity, or the drug induced. This is our team going to some of the village. These are the patients we are treated, are given the opportunity to dance, play, beside the common things. So that's a support group activity goes on. So thank you very much for the patients here.
Okay, Nomal, thank you very much and congratulations. I was not aware about the real impact these camps had in Maharashtra in India in improving patient care in epilepsy. And what you clearly pointed out, that epilepsy is all neurological disorders, but also epilepsy. It's not just prescribing drugs. It's a multidisciplinary problem which affects quality of life and needs multidisciplinary treatment. I see that it's certainly difficult to do it with these semi-professional helpers. It's certainly a good way, as well as using these WhatsApp and telephone interaction with patients. You know, the World Health Organization has this International Global Action Plan that was labeled for epilepsy and neurological disorders. So epilepsy was very much in front of the scope also of WHO. I think neurology, of course, goes far beyond epilepsy, but nevertheless, it was a good, let's say, a good entry point. Let me look at the question answer section. There are no real questions except one, which is a real question. Someone is asking Dr. Sakal from the UK how to increase clinicians' engagement for high-tech.
I just wanted to thank you that you have included epilepsy special interest group in the WFNR. I think they need
definitely we did. Yeah, we were missing that for a while. And that was probably my mistake. I don't know, but nevertheless, we solved it out now, right? It's an important issue, no doubt about it. It's a symptom. It's not a disease as such, but nevertheless, it's a very important aspect which we certainly have to pay attention to, no doubt about that. So coming back to this question by Dr. Sakal, how to increase clinicians' engagement for high-tech use, for instance, BCIs, and this is a quote from the UK. Good question. How can we increase the inclination of clinicians to use high-tech? Any comments from your side?
From me, I think.
Marina.
But it is a good question because it's a question that outlines the role of neurophysiology in the recovery of patients as a new tool. We understand and we consider EEG only a strategy to assess some symptom of patients, such as epilepsy, or to understand if the brain of patients has some alteration of activity. In BCI, the use of EEG is to provide signals that we, with a specific strategy, a specific algorithm, a specific condition, can be used to translate the brain signals in external command. This is a very interesting field because EEG, with the evoked potential, is among the neurophysiological tool the most important in the last time. And also how we can promote the use of BCI. We can promote the use of BCI at first to having a good to have a good assessment of patients and to establish which is the main problem and to establish the aim of rehabilitation. All the new technology must be used with this purpose. For example, robot therapy can be used to enhance the strength of the arm or of the leg. The BCI is a more complex system because is the translation of thought in movement. And in the last time, there is a tendency to combine more technology in the same time to obtain the best of recovery of patients. Then, as we talk about of multidisciplinary treatment, we can also to merge multidiscipline or multi-tool for rehabilitation of patients.
Well, that's certainly right. It's interesting to note about 100 years ago when Hans Berger started up the idea with EEGs, his conceptual framework was that you could read the brain. And in some sense, this is useful today when you fuel it into brain computer interfaces 100 years later. Nevertheless, I think that there is let's say the implementation of high-tech systems, maybe robotics, maybe even simple things as treadmills, robotics, brain-computer interfaces, neuromodulation techniques, TCDS and others, is more and more coming up, and more people getting an interest in that. And I think that, but of course, that takes a while. It's not that it's implemented within a year or 2 or 5. With robotics are now implemented in many areas. We started off with these robotic work about 25 years ago, and today they are very frequently used. Treadmills even more. That was started a couple of years earlier. So that is gradually improving. As I mentioned, however, that this is not the only solution to neurorehabilitation, to be honest. Let me ask, if I may, a question to Mayova on the community-based rehabilitation. I think you gave a beautiful overview on the, let's say, conceptual framework, on the caveats as well. And the question to you, from my side, basically is what can be done and what is necessary to spread this idea on a much, much larger scale. So how can we scale up the community-based rehabilitation idea?
Thank you very much. I think the basic units that we can work with are the primary healthcare centers. There are primary healthcare centers in many low and middle income countries. And in fact, in some countries, they have a department of the Ministry of Health that is in charge of primary healthcare centers. Primary healthcare centers have been used for so many to deliver a lot of services. I mean, to screen people for hypertension, they've been used for immunization, and so on and so forth. So these primary healthcare centers can be leveraged to deliver community-based rehabilitation. And that is, first of all, by identifying who are those people, the health personnel, what category of health personnel are in those primary healthcare centers. In some places, they have doctors, they have nurses, and they have what is called some category called community health extension workers. So they will have some some basic knowledge about some basic medical knowledge. They are paramedicals. I mean, many of those, apart from the doctors and the nurses, are paramedicals. Perhaps what can be done is, if there are workshops, first of all, I think we need to protocolize what can be delivered, the kind of things that can be safely delivered as a community in the community-based setting. So I think if experts come together and protocolize what can be delivered, for instance, for hypertension, it is protocolized already. What kind of hypertension can be treated at the community level without necessarily the need for a doctor to make prescriptions? What kind of BP band, what kind of red flags would make them refer the patient? So if we have something protocolized, and then we then organize training with certification of those paramedicals, then they will then be able to deliver these services because we'll have more of them than doctors, than therapists, than nurses. They will then be able to deliver the in the community centers, most likely, I mean, most probably the primary health care centers, to patients who need those services as a bridge between what they are doing for themselves at home, as self-care or family-based care, as a bridge between family-based care and self-care and hospital-based care. So they can then serve as a bridge. So, but this category of workers will need to be identified, trained, certified, and of course, they will need to also be told what the lines are, I mean, their boundaries have to be defined. And they must then be supported, by tele-rehabilitation tools or by very robust referral mechanism. And they would also help not only in just the care of the patient in terms of helping the patient to improve, but also in community integration, in vocational integration, in integration back to work, family life and all that, because they are very close to the communities. They know the people, they live in those communities, and so they will be able to do this work as social workers as well as rehabilitation workers. I think that's the way it can work.
I think what we have
Thank you very much.
thanks, Mayor, what we try to achieve basically is how we can scale up these multiplication factors. The basic idea is to have multiplication factors coming around the paucity of available professional therapists, nurses, and whatever have you, physicians. Well, I'm absolutely certain that these digital communication tools will be helpful. We talked about that some days ago in the task force of the WFNR on CVR, and I think we, in some sense, excuse me as being a very Prussian German thinking person.
Pragmatic.
Yeah, no, we have to do really systematize that. I think the idea is excellent, and basically I think also the tools are available, and we have to make our mind up how we can spread that in the best way. Allow me when I'm a little bit strict in this respect, but I think it's necessary. Coming back to Nirmal, if I may, I very, very much like this idea of the epilepsy camps you mentioned in Maharashtra. And this is certainly a concept which is worthwhile to be spread around the world in most countries who have this problem. That is, we have to think about that. That is also a project which I would think is also on the scope of WFNR to pursue in future. Very much similar to the CVR initiative we are running at the moment. Let me ask you a specific question. I know that many of the anti-epileptic medications today are produced in India. India is probably the biggest producer of pharmaceuticals in the world today. Do you have a paucity of access to these drugs in India still, or is this not the problem?
The government hospital, most of the government hospital across the country only have 4 anti-epileptic drugs.
Okay.
Phenytoin, phenobarbital, carbamazepine, and sodium valproate. So when I started the rural service, my first condition was that I need proper medication. So I bargained with the government, and I got 8 anti-epileptics. So my contract, I got a notice from them that this will include oxcarbazepine, clobazam, lamotrigine, and topiramate. And for the last 4 years, I've also got levetiracetam added. The government initially was giving 15 days medicine, and now they spend nearly 3.5 lakh rupees, which is about $4,000 for a camp for 1 day. So all the patients who come, and we buy about 400 to 500 patients, 3-month medication. So if we don't finish that, they get a follow-up after 3 months, they can come and collect that medicine. So government is very keen. This project has gone into it. That's the reason it has been running for last 13 years. Otherwise, there's no other project of government which is running for 13 years. And the results are there. So basically, if you give the medication, the patient get better. As we say, 70% of patients are going to get better if they provides a proper diagnosis by the neurologist, because in each camp, like I had a camp last Saturday, which is about 1,000 kilometers from Mumbai, and Sunday, which is in an area which is a tribal area, which is border of Maharashtra with 5 states, Telangana, Chhattisgarh, MP, Andhra Pradesh, all of them are border of that Gadchiroli, very scary area. But we did a camp there. This is not the first time. My Bandara camp was 4 times and Gadchiroli was 3 times. And in last 12 years, what I've been seeing is what I was seeing 10 years ago. There's a tremendous change in the education awareness, and the people are coming forward for the camp and taking the medicine. They are looking out for the camp. Of course, in Gadchiroli, the issue was different, that there were many patients who were not taking the medicine, or they took the medicine and stopped. Bandara, it was not there, because Gadchiroli, there is no neurologist visiting. But Bhandara, there are local neurologists. So wherever there is a local neurologist available, the quality of epilepsy care improves. And that's why we want to establish a regional epilepsy center across the Maharashtra.
You need knowledge to improve the situation. That's basically the answer. Spreading knowledge certainly is of paramount importance in this respect. Any questions from one of the speakers to any of the other speakers at the moment?
I have a question for Nirmal, please. Very short question. The patients have access only one choice in the therapy, or it is possible also to have more than one therapy? You mentioned carbamazepine, but the most recent therapy for epilepsy has combined new strategy for protecting brain and medicine, as you know, of course, to for the seizure. And then I think is a very important aspect, because also in the high-income countries, the access to all the therapy for epilepsy is not so easy in any case.
So the principle of treatment is monotherapy. If patient do not respond to monotherapy, then the polytherapy. So you add on another drug. So, and that is being followed. So we always start first drug. If a patient continue to have seizure after the first drug, then we add into another drug. Many diseases like myoclonic epilepsy, absence seizure, they get better with single drug. Many focal seizure respond wonderfully well to the carbamazepine or oxcarbazepine. But if they're not, then there are choices of adding lamotrigine, levetiracetam, topiramate for different kind of epilepsy. So that neurologists, when they see, they decide about what should be the line of treatment for that.
Okay.
Thank you.
Any more?
And Mayowa, we have been working with 9 countries of Africa. I have had a couple of meetings, and in fact, during COVID, we want to help out to provide the medication, because I believe the anti-epileptic drug is the biggest challenge in Africa. We've worked with Action Amos and other people, and I'm trying to build up through our honorary consul general, which are many of them are my friend, particularly Rwanda, Uganda, DRC. So in Congo, we have actually helped them out to get a EEG machine, paste, electrode to this thing. So we are trying to establish if this model can be, tried same way in Africa, in some of the country, and maybe another next 1 or 2 years, it may be possible that we decide either at Rwanda or Uganda as the first center to establish a epilepsy center with India and Africa.
Mm-hmm.
Okay, there's one more question from Dr. Mohammed Sakal from the UK to Namal. How much value does Professor Surya attach to the perspective of charities like Epilepsy Association? Yeah, a good question.
Well, it is the dedication, anybody who is dedicated, like I go into the camp, I sit at 9 o'clock in the morning, only get up last in this. I report all the EEGs and I re-see them, the patient who have been referred for EEG. So I've reported more than 4,000 plus EEG. We have developed a EEG protocol, and our protocol is 7 minutes because we start with the 1 minute in normal EEG, 3 minutes hyperventilation, and 3 minute post hyperventilation. So this 7 minute EEG has a yield of 45% in the rural camp. So this is I've written about it. I presented this in American Epilepsy Society annual congress in New Orleans a couple of years ago. So this 7 minute EEG is a yield as much as 30% because we select the patient who never had a EEG or where the treatment needs to be changed or where the diagnosis is doubtful. So those are the patients which are done the EEG. So we have, it is all about dedication. Because I sit down, I see each and every patient. I see to it that everywhere the things are done. Anybody who is dedicated, I think he will make a difference in the life of the people. I think that's the simple thing.
Yeah, sometimes things are simple, but mostly not. Okay.
And Mohammed Shakir is a friend of mine from Bangladesh. He is in UK,
yeah.
so he's a great man. Nice to see him here, and I'm really happy to see him.
Okay, I think there are no further questions coming up. Let me thank the contributors very much. I think we learned very much. I learned a lot today, which was not really on the scope of my mind at the moment. And WFNR will certainly pursue these aspects with a new emphasis on epilepsy as well. Normal, it can be about that. And of course, we go on with the community-based work as well as with.
So Guhan, I called him for 2 camps in the Bandara and Gadchiroli, who has applied for the 6. So I say, you must see what is happening in the rehabilitation in epilepsy. So he attended both the camps. I think it will be useful.
Definitely discuss this in Vancouver as well. I think that's a very important aspect.
Yes.
Okay, so thanks all of you very much. I also may express my gratitude to Christian Raul and our glorious team in Romania, who helps us to arrange for all the technological details and setting this up. So Christian and Raul, thank you very much again.
Thank you
for your help.
Thank you.
And,
thank you. And good night to all of you.
Take care until soon. All the best. Thank you very much.
Thank you very much.
Ciao.